Chapter 3, Nutrition Assessment, Foundation of the Nutrition Care Process. Learning Objectives. Explain the purpose and importance of the nutrition assessment. Explain the difference between nutritional status and nutritional risk. Differentiate between nutrition screening and nutrition assessment. Describe the types of data that can be collected during a nutrition assessment. Describe the different methods used to collect data on dietary intake. Compare tools used to evaluate dietary intake. Distinguish between methods of anthropometric measurements and body composition measurements. Discuss biochemical assessments that can determine nutrition status and which ones are not reliable. Describe the purpose and techniques for performing a nutrition-focused physical exam. Discuss methods used to estimate energy and protein requirements of individuals. Recognize etiology-based malnutrition definitions. Just as the physical assessment is the cornerstone of medical assessment, nutrition assessment provides the foundation for the nutrition care process. It is based on information gathered in the nutrition assessment that nutrition problems are identified and the nutrition diagnosis can be determined. After intervention has been put into place, nutrition assessment data serves as benchmarks with which to measure the effectiveness of treatment. Methods for nutrition assessment vary depending on the population, the nutrition diagnosis, and the desired outcome for the nutrition therapy. There is no single test that measures nutritional status. Determination of nutritional status involves evaluating indices that reflect the body's nutrient stores. Nutritional status is altered when stores of energy, protein, water, vitamins, or minerals fluctuate as a result of increased need, increased or altered utilization, or altered intake. Today, in most developed countries, concern for nutritional status focuses on the effect of excessive intake of nutrients and energy. Determination of nutritional risk involves the attempt to predict potential nutritional problems based on the client's current health status. Pathophysiology is defined as alterations from normal anatomy and physiology that occur as a result of disease or injury. Understanding pathophysiology, treatment, and clinical course of disease or diagnosis allows one to identify nutrition problems for an individual and ultimately determine the nutrition diagnosis. As a component of the nutrition care process, the nutrition assessment consists of gathering data in the following areas or domains: food and nutrition-related history, biochemical data, medical testing and procedures, anthropometric measurements, nutrition-focused physical findings, and client history. Assessment data from these areas may be both subjective and objective in nature. The assessment process then moves to analyze the data so that current and potential nutrition problems can be identified. The World Health Organization defines screening as the use of simple tests, a healthy population, in order to define or identify the individuals who have disease but not yet have symptoms. The Academy of Nutrition and Dietetics uses this as its basis for defining nutrition screenings, which is a process of identifying patients, clients, or groups who may have a nutrition diagnosis and benefit from nutrition assessment and intervention by a registered dietitian nutritionist. Nutrition screenings can be performed by a dietetic technician or other trained professionals, which allow for more efficient and cost-effective data collection and identification of an at-risk population. A dietitian can then perform a full nutrition assessment for those identified as being at nutritional risk. The Joint Commission on Accreditation of Healthcare Organizations require that all patients receive nutrition screenings within 48 hours of their admission. Subjective data includes information that is obtained directly from the patient, family members, and any other caregivers, usually during interviews. Subjective data would include the client's perception of his or her medical condition, dietary intake, lifestyle conditions, current medications or supplement intake, and family medical history. The interviewer observations are also considered subjective data. Examples of subjective food/nutrition related history assessment. Category: food and nutrient intake. Mother reports her child's food intake for previous 24 hours. Behavior: patient decides that she will eat only while sitting at kitchen table with family members as a step to decrease snacking behaviors. Factors affecting access to food and food nutrition related supplies. Patient reports that he has access to a microwave but does not have a stove or oven. Physical activity and function. Patient states that she is unable to walk up more than one flight of stairs. Nutrition-related patient client-centered measures. Patient voices that she sees no benefit to improving blood glucose levels. I have tried different diets and I do not think it will make any difference for my diabetes if I change my diet. Objective data includes information obtained from a reliable source such as the current medical record or previous medical histories. These data could include anthropometric measurements, biochemical data, and results of medical tests and procedures. We want to make sure this information is verifiable. Objective nutrition assessment information with examples. So anthropometric data could be height, weight, BMI, biochemical lab results that may be of nutritional relevance. So visceral protein assessment without inflammation, like albumin, transferrin, prealbumin, and total protein. Hematological assessments, hemoglobin, hematocrit, electrolytes, sodium, potassium, chloride, others like blood glucose. Nutrition-focused physical findings. This could be oral health, the lip, tongue, gums, and teeth, head and neck, nails, blue or pale nail beds, reduced grip strength. Muscle mass, skin, fluid accumulation, client history, their age, gender, education level, food security, and socioeconomic data, previous medical history and testing that impacts nutritional status. Many social factors, including socioeconomic status, education level, social support system, interaction with other people and lifestyle, impact nutritional status. It is vital to identify those factors during the interview because they will impact nutritional status. Economics directly impacts nutritional status. Obviously, nutrition education has little meaning for clients who do not have access to adequate food for themselves or their family. High food security. Household had no problem or anxiety about consistently accessing adequate food. Marginal food security. Household had problems at times or anxiety about accessing adequate food, but the quality, variety, and quantity of their food intake was not substantially reduced. Low food security. Households reduced the quality, variety, and desirability of their diets, but the quantity of the food intake and normal eating patterns were not substantially disrupted. Very low food security. At times during the year, eating patterns of one or more household members were disrupted and food intake reduced because the household lacked money or other resources for food. During the interview, the ability to communicate should be established. The client's primary language, as well as the ability to speak, write, read, or comprehend both the primary language and English, can be determined. Educational level, attention span, long-term and recent memory, and readiness to learn can all be established during the initial interview. Perception of health status and the client's desire to improve health or be involved with healthcare are crucial determinants of successful nutrition education and intervention. Client interviews and subsequent data collection can be organized using a number of tools and instruments. Many institutes design their own data collection tools based on the nature of the population and the intended use of the data. Standardized instruments such as Determined Checklist, Subjective Global Assessment, SGA, Malnutrition Universal Screening Tool, MUST, Nutrition Risk Screening 2002, and numerous others are used for specific population. Academy of Nutrition and Dietetic evidence-based analysis for nutrition screening identifies 3 tools from the literature: the Malnutrition Screening Tool, Mini Nutritional Assessment, and Malnutrition Universal Screening Tool. Typically, food and nutrition information is assessed by collecting data retrospectively or summarizing data gathered prospectively. All methods have their own strengths and limitations. The accuracy or validity of the information and the reliability of the data depend on the experience and skill of the clinician, the cooperation and accurate reporting of the client, and the type of assessment instrument that is used. When using a 24-hour recall as the dietary assessment method, the clinician guides the client through a recall of all food and drink that has been consumed in the previous 24-hour period. The clinician asks what food or beverage was consumed most recently prior to the interview, and then works in reverse order through the previous 24 hours. The clinician can question the client about activities during the period in order to stimulate the client's memory. The USDA multiple pass approach, a variation of this method, is widely accepted and validated method that includes 5 standardized reviews of information. Advantages of the 24-hour recall method include short administration time, minimum cost, and slight risk for the client. One disadvantage is that a 24-hour recall does not always reflect a typical eating pattern, since day-to-day dietary intake may vary considerably. A second disadvantage is that clients may report information they feel the clinician wants to hear. An example of a 24-hour recall is figure 3.5 on page 45. Components of a 24-hour recall: note the time the food or beverage was consumed, record the food or beverage, determine serving size for food or beverage, determine how the food was prepared, determine where the patient had the food or beverage, include any relevant notes to the food or beverage record. Nutrition care indicator, food record or diary. In this method, the client documents his or her dietary intake as it occurs over a specific period of time. Typically, the record is kept over a 3 to 5 day period and should include a sampling of both weekdays and weekends. Clients estimate or measure their food intake. The advantage of this method is that it is not totally reliant on the client's memory, or may be a more representative of the client's actual intake. Validity may be low because underreporting is common. Accuracy is dependent on the client's accurately reporting typical daily intake. There is a heavier burden on the client, who must make a commitment to record his or her intake. Many online tools and applications have been developed to assist the client in preparing a food record or tracking their intake electronically, such as MyFitnessPal. An example of a food diary is figure 3.6 on page 46. The food frequency data collection method is a retrospective review of specific food intake. Foods are organized into groups, and the client identifies how often and in what quantities he or she consumes a specific food or food groups. The method can be self-administered. Many food frequency instruments are specialized and validated to identify food group intakes for certain disease states, such as cardiovascular disease, are designed for use of a specific population. Advantages of this methodology are that it is inexpensive and require minimum time to administer. Disadvantages include a tendency towards lower responses because the instrument is self-administered. The instrument may not include ethnic or child-appropriate foods or quantities that are realistic for those eating larger amounts, such as athletes. An example of a food frequency instrument It's figure 3.7 on page 47 and 48. In an acute care or long-term care setting, actual food intake can be observed and recorded when a kilocalorie or kilocalorie protein count is ordered. Specific procedures for this method may vary from institution to institution. If very detailed information is required, as the case of research or metabolic study, food may be weighed before and after the meal is served. In most institutions, nursing or nutrition staff document what the patient eats from the meal tray. The registered dietitian nutritionist or registered dietetic technician then calculates nutritional information such as kilocalories or protein content from this information. If the RDN or DTR collects this information, it provides an excellent opportunity to assess the patient's understanding of any dietary interventions and to teach specific nutrition information such as portion control strategies or nutrient content of the meal. After data are collected and analyzed, it is the clinician's job to compare the information to establish scientific reference criteria. These criteria may include the individual patient's needs and may be as general as comparison to the United States Dietary Guideline or as specific as milligrams of vitamin C. The 2015-2020 Dietary Guidelines for Americans provide general recommendations for dietary intake that promote health and prevent disease. These guidelines are based on decades of research and reflect the most up-to-date evidence-based information supporting the understanding of nutritional requirements. Dietary analysis using the My Plate recommendations can quantify food consumed from each of the major food groups. These data give the clinician an overall look of the adequacy, variety, moderation, and balance. Food list for diabetes weight management. This method of analysis uses the food list established jointly by the American Diabetes Association and the Academy of Nutrition and Dietetics. Use of this list provides a quick, rough estimate of kilocalorie, protein, carbohydrates, and fat in the diet. The USDA first published food composition values in 1896. The Nutrient Data Laboratory of the USDA maintains and updates the National Nutrient Data Bank system. Historically, this information has been published in a series of agricultural handbooks, but now is available only online. Web-based dietary analysis. Nutrition professionals and consumers have access to many sources of digital dietary analysis programs. These programs vary significantly in terms of number of food items, nutrients included in the database, accuracy of the data, how often the information is updated, cost to access the program, and ease of use. One method of evaluating dietary macro and micronutrient amounts is the use of the Dietary Reference Intake, DRIs, and the daily values, DVs. DRIs are standards established by the National Academy of Sciences. These standard references values allows evaluation of energy, protein, vitamin, and mineral intake for healthy people. There are 4 different sets of standards within the DRIs: adequate intakes, recommended dietary allowances, tolerable upper intake levels, and estimated average requirements. It is important when using these standards to understand the context in which the references are established. In the clinical setting, many patients have specific diseases or medical conditions that may have unique nutrient requirements. For an example, an individual with a burn injury may require significantly higher doses of vitamin C and zinc to ensure appropriate wound healing. The DVs were established by the Food and Drug Administration to assist consumers in interpreting nutrition labeling information. The dietitian will use much more specific, individualized reference data for assessment, but certainly may use the DVs as an educational tool. Because nutrition is a crucial component of normal growth and development, it is accepted practice to measure body compartments in order to evaluate infants, children for appropriate growth. In normal, healthy individuals, the relationship among body storage compartments are relatively stable, but when disease or stress is present, changes in the storage compartments are an important aspect of nutritional status and risk. Nutrition care indicator: height, stature, length. Measurement of supine or standing height is necessary for monitoring growth of infants and children from interpretation of weight in adults. For children under the age of 2, length is measured recumbently using a length board. Over the age of 2, standing height is measured using a tape measure, as long as the child can follow instructions and remain standing for the measurement. Sometimes a client cannot stand for a measurement of height, for example, because he or she is disabled or confined to a wheelchair or bed. In these cases, any of the several estimation methods may be used. One method is the arm span. The client extends the arms from the body at a 90-degree angle, and distance is measured between the tips of the 2 middle fingers. The length of the dominant arm can be measured in the same fashion and multiplied by 2 to estimate the height. A limitation of this method is that it is an estimation of maximum adult height and not actual current height. Knee height is another method of height estimation. Measurement of knee height uses a knee height caliber to be taken when the client is sitting or in a supine position. Nutrition care indicator: weight. Weight can be measured using a variety of scales, including balance beams and electric scales. Bathroom scales and those that move frequently are not recommended due to poor calibration. Wheelchair and bed scales are available for non-ambulatory patients. For those patients with an amputation, weight has historically been adjusted using the following factors: hand, 0.8%, forearm and hand, 3.1%, entire arm, 6.5%, foot, 1.8%, lower leg, below knee and foot, 7.1%, entire leg, 8%. Adjusted body weight equals actual measured weight divided by 100 minus percent of amputation. The whole equation is then multiplied by 100. Weight and height for infants and children are evaluated using growth charts developed by the World Health Organization, CDC, and the National Center for Health Statistics. Determination of height for age and weight for age allows comparison of an infant or a child to a reference population. It is recommended to use the World Health Organization growth standards for infants and children less than 2 years of age and use the CDC standards over age 2. Weight and height and percentile weight for height can also be evaluated using CDC growth charts. These measurements allow evaluation to be independent of age and can be used to monitor acute malnutrition or incident of obesity. In the clinical setting, variation from usual body weight have been strongly linked to nutritional risk and health complications. In general, as an adult is considered at nutritional risk if there is a greater than 5% unexplained weight change in less than 1 month and greater than 10% in a 6-month period. The concept of unintentional weight loss is also included as a criterion in the proposed definition of malnutrition. Percent usual body weight is calculated as current body weight divided by usual body weight multiplied by 100. Present weight change is calculated as present body weight minus usual body weight divided by usual body weight multiplied by 100. Height weight tables and body weight recommendation estimated for these data were initially created by the life insurance industry. These data have been criticized and their use is discouraged as the original population does not correlate with the current population in the United States. In many clinical settings, reference body weight is calculated using Hamway equation, even though it does not adjust for differences in age, race, or frame size. BMI is calculated as weight in kilograms divided by height in meters squared, or weight in pounds divided by height in inches squared times 704.5. BMI has been well correlated with overall mortality, disease, and nutritional risk. It is crucial to remember that BMI does not distinguish between body compartment and therefore does not estimate body composition. Still, the BMI measurement is better at indicating obesity than mere height and weight alone. Waist circumference of greater than 40 inches or greater than 35 inches for women is considered to be predictive of obesity and chronic disease risk. Additional assessment using their waist circumference measurement or the waist to hip ratio and waist to height ratio. The measurements are used to assess risk of obesity-related diseases that are associated with android fat storage pattern. I want to say again, waist circumference in men greater than 40 inches or greater than 35 inches for women is considered to be predictive of obesity and chronic disease risks. Height and weight, though crucial components of nutrition assessment, are only gross measurement and cannot distinguish among body compartments. It is not unusual then for very muscular individuals to fall in the overweight or obese category when only height and weight are used in the nutrition assessment. Body composition refers to distribution and size of all components contributing to total body weight. In most clinical settings, body compositions refer to two major components of total body weight and fat-free mass. A more thorough definition would include fat and muscle mass, together body water and bone and teeth. Nutrition professionals are more concerned about metabolically active tissue and fluid status. Skin fold measurement is used to estimate energy reserve, both fat and somatic protein, in subcutaneous tissue. Skin fold measurement involves measuring a double fold of skin in subcutaneous adipose tissue while excluding muscle tissue. Skin fold and mid-arm circumference measurements, as well as the index calculation for mid-upper arm muscle circumference, mid-upper arm muscle, and mid-upper arm fat area, can be compared to reference that are based on NHANES summary data. An individual who is below the 5th percentile or greater than the 85th percentile may be at nutritional risk. Please review Appendix D1, page A-73 for these reference standards. When interpreting these measurements within a nutrition assessment, it is important to recognize that these reference standards were developed using a healthy population and should not be used for patients in a disease state. Multiple site skin fold measurement can be used to estimate body density and body fat percentage. Bioelectric impedance analysis, BIA, is a common procedure used to estimate body composition. It is considered to be rapid, safe, portable, and non-invasive method of an assessment. A small, low-frequency alternating electrical current is administered at one extremity of the body. Measurement of impedance of the electrical current can then be used to estimate components of body composition, including body cell mass, fat-free mass, fat mass, and total body water. Multiple frequency BIA may provide a more accurate assessment than a single frequency. Regression equations used to estimate body composition with BIA measurements include age, gender, weight, height, resistance. Even though the use of BIA has continued to expand in recent years, BIA should not be used to assess body composition in patients who have experienced major shifts in water balance and distribution. Assessment of data from numerous sources supports the appropriate nutrition intervention and plan of care. These data include information gathered during medical procedures such as a barium swallowing test as well as biochemical nutritional markers and indicators of organ function, which are found in blood, urine, feces, and tissue samples. Disease states, presence of inflammation, hydration status, and subsequent treatment can have considerable effects on the level of the biochemical indices and thus dramatically affect their reliability and nutrition assessment measures. Protein unique function in supporting cellular growth and development elevates its significance in nutrition assessment. Even though a large amount of protein is stored in muscle and visceral, the body strives to protect it from being used as an energy source. Protein assessments have focused on evaluation of two components: somatic and visceral. Somatic protein refers to skeletal muscle, and visceral protein refers to non-muscular protein. CHI, creatine height index. Creatine height index. Creatinine is formed at a constant daily rate from muscle creatinine phosphate. Creatinine phosphate, which is stored in muscle, provides the phosphate group needed to regenerate adenosine triphosphate during high intensity exercise. For this test, 24-hour urine collection is performed, and total amount of creatinine excreted in the 24-hour period is compared with either a standard based on height or a standard excretion from a particular reference individual of a specific height, gender, and age. In healthy individuals, nitrogen excretion should be equal to nitrogen intake, thus indicating a state of nitrogen balance. A negative nitrogen balance develops when nitrogen excretion is greater than nitrogen intake, indicating catabolism or inadequate nitrogen intake, whereas a positive nitrogen balance occurs when nitrogen intake is greater than excretion. In order to measure nitrogen balance, the dietary intake of protein for a 24-hour period is estimated, while a 24-hour urine collection is gathered to measure total excretion of nitrogen. Visceral protein refers to non-skeletal protein making up the organs, structural components, erythrocytes, granulocytes, and lymphocytes, as well as other protein found in the blood. Serum protein measurement is affected by a change in the amount of amino acids needed for protein synthesis by the liver. A change in serum protein levels would be consistent with changes in visceral protein status. Albumin, blood transport protein component of a vascular fluid and electrolyte balance, can be transferrin, iron transport. Remember, reference values may differ by laboratories. Many other biochemical labs are routinely assessed and monitored. These may include measures of lipid status, such as LDL cholesterol, HDL cholesterol, or triglycerides. See Table 3.2 on page 64 for a summary of routine emission laboratory measurements. Also review Appendix E on page A-74 and A-75. In addition to the physical examination performed by medical and nursing staff, the dietitian should routinely perform a nutrition-focused physical examination for at-risk patients. The purpose of this physical exam is to assess the patient for signs and symptoms consistent with malnutrition or specific micronutrient deficiencies. The methodology and interpretation for the nutrition-focused physical exams or assessments are included in Appendices F through G, and see Table 3.13 on page 65 for example findings. Functional assessment focuses on measurements that assess skeletal muscle function or strength. Additionally, assessments could be expanded to include those activities that require adequate strength. For example, in the SGA, questions that focus on activities and functions are included. The SGA identifies the patient's perception of his or her ability to accomplish self-care and the environment where the patient spends the majority of his or her time. Another method of functional assessment is the identification of specific ADLs, or activities of daily living related to nutritional status. A valuable assessment of muscle strength is hand grip, used to determine the hand grip strength. This is standardized, simple, and quick means of assessing nutrition in relation to skeletal muscle function and is incorporated into the proposed criteria for malnutrition diagnosis. Activities of daily living and instrumental activities of daily living. So activities of daily living includes bathing, showering, bowel and bladder management, dressing, eating, feeding, functional mobility, personal device care, sleep, rest, and toilet hygiene. Instrumental activities of daily living, care of others, care of pets, child rearing, communication device use, home establishment and management, meal preparation and cleanup, safety procedures and emergency responses, and shopping. The final component of nutrition assessment is determination of energy and protein requirements for the patient. This step is necessary in order to compare intake with needs and to establish nutrition goals. In most clinical settings today, protein and energy requirements are established using a variety of established equations. In some situations, it may be possible to measure energy needs by using indirect calorimetry, and protein needs by performing a nitrogen-based balance study. The total amount of energy required by an individual is the sum of three basic components: basal energy expenditure, BEE, or basal metabolic rate, BMR, plus energy for physical activity, plus thermal effect of food, TEF, equaling total energy expenditure, TEE. Basal energy expenditure is defined as energy used for psychological function that maintain life, such as respiration and heartbeat, and accounts for approximately 60% of an individual's energy requirement. BEE is assessed by measuring the oxygen consumed by an individual who has gone without food for at least 12 hours and has been laying down with little movement in a constant temperature environment overnight. In many discussions regarding energy, the term resting energy expenditure, REE, or resting metabolic rate, RMR, is used. Resting refers to measurement conditions where the individual is resting in a comfortable position without other restrictions. RMR is usually estimated to be approximately 10% higher than BMR or BEE. Physical activity is the most variable portion of an individual's energy needs and fluctuates depending on the type, duration, and intensity. In hospitalized or diseased population, many individuals are hypometabolic and have additional energy and protein requirements. Indirect calorimetry. The most accurate method of measuring REE or RMR in a clinical setting is to use indirect calorimetry. The equipment used for this process has steadily become more sophisticated over the last several decades. Basic principle: the amount of oxygen and carbon dioxide in both inspired and expired air are measured. The volume, the V of gas exchange is equal to known energy constants. Values are then converted to REE or RMR using computer software within the equipment. The use of direct calorimetry is becoming more increasingly popular, although cost and availability of equipment continues to limit its routine use in many institutions. It is more common in clinical situations to calculate an estimation of an individual energy requirement, and therefore clinicians may rely on prediction equations. The newest critical care nutrition guidelines state that while there are more than 200 published equations, their accuracy is high variable. Each patient needs are highly individualized, and this affects the accuracy of any equation used. The first established equation was the Harris-Benedict equation, first published in 1919. There are different recommendations for practices for choosing the body weight used with each of these equations. It is more difficult to accurately predict energy requirements in either the underweight or obese patient. Table 3.15, estimation of energy requirement. Harris-Benedict equation, Mufflin, St. Jour equation, American College of Chest physician equation. A nitrogen balance assessment measures urine, urea, nitrogen, and compares it to protein intake. This allows for some degree of measurement of protein requirement. The RDAs provide the best reference for protein requirement in the non-stressed population. For adults, this level is set at 0.8 grams of protein per kilogram of weight. In the nutrition care process, after all components of nutrition assessment has been compiled, the clinical nutritionist determines the nutritional status of the patient and identifies specific nutrition-related problems. As a component of an overall nutrition care process, specific nutrition diagnoses arise from the nutritional problem identified during the nutrition assessment. Healthy is strongly influenced by nutritional status. It is no surprise that the Joint Commission for Accreditation of Hospital Organizations require that all patients receive nutrition screenings within 48 hours of their hospital admission. No one test exists to assess nutritional status. In this chapter, numerous measures of dietary intake, physical health, and biochemical status has been presented. In practice, these measures allow the clinician to determine not only current nutritional state, but also future nutritional risk.